And I promised in the last session that we would tell you exactly how to really nail the blood vessel, the causative lesion in upper GI bleeding. And that's what this session is about, as well as some other GI emergencies. And we'll have a nice live case performed by Lobke de Zomer and Stephen Heitman. Session objectives are to understand how advanced techniques from interventional endoscopy space can be applied to all GI bleeding scenarios. Something that we're really going to put our foot down on in the next year with the GIEQs project is to truly try to bring the interventional space to GI bleeding. And I hope that we can make a start in this session.
Do work in interventional healthy tissue. To summarize, know your different modalities. If you know what is out there, you can change your plan. If your plan A does not work, go to plan B. Use the ABC principle, characterize your blood vessel, think Holy Trinity, cap, water, high definition scope. Think about the fan principle to find the bleeding source. Think first thermal and then mechanical. And don't forget about the compliance principle, where the tissue is compliant in interventional, but often less compliant in acute setting and mainly in ulcerative bleeding. And if your vessel is large, over 2 millimeters, you might think to take out an over-the-scope clip.
And then a small word on food bolus impaction in the esophagus. This is quite important because over 75% of these patients have a esophageal pathology, which is mainly strictures, but also esophagitis, motility disorders such as achalasia, cancer, diverticulum post-surgical. So they always need a diagnostic workup, which means at first biopsies, but that can be at the index endoscopy or at a repeat endoscopy after PPI. There's also some literature on glucagon, 1 milligrams IV. This can be tried, but there's only limited evidence that it works, and it's not effective if there's an anatomic abnormality, which is in most patients. And it's counterindicated if the patient has a full esophageal obstruction, because it can induce nausea, vomiting, and it increases the risk for aspiration. If you give it, you should evaluate the risk after 15 to 30 minutes, and this should not delay your endoscopic intervention if this is not successful. And if you do an endoscopy, of course, first try to gently push, and if this is not successful, then you retrieve the foreign object.
Hi, can you hear us?
Yeah, we can.
Okay, so we've put the hood on.
Okay.
And I've stayed in the esophagus because I've put a hood in before, went in the stomach, and it nearly already, flopped over. How do you say? So I decided to come back out, put it back on properly, and stay in the esophagus to show you better. So it's not difficult at all to intubate. It's a very floppy thing. It's a bit of a thick caoutchouc. You see it here already. See, I'm going through the GOJ, and immediately, that's a little bit the problem with it. So what I was going to do is grab a rat tooth forceps, and then I'm going to grab it at the end and try and get it parallel with the esophagus. So I hope that my visualization will not get worse than it already is. But what actually should happen is that the capuchon or the hood folds back as I go back through the GOJ to proximal. But it's a floppy thing. You have no control over it. So let's see if I can manage to do it with this view open.
Nice. Lob, while you're doing that, if you don't mind me talking over you, I saw on the questions that there was a question about, do you use a hood? Well, of course, this is an audience question, and beautifully you're demonstrating that it's almost certainly the right thing to do here.
Okay. So I'm going to reopen because Emily is saying she's got it only on the edge and we're not trusting. We don't want to drop it. Close. But maybe I should have gone for it, I'm thinking now. Yeah,
it's quite finicky, yeah. But you do have, quite a buffer with the hood.
That's better.
That's the point.
The only thing is now we don't really have it parallel. So open again. Remember, perfection is the enemy of good. Right, Steve?
That's right.
Close. But I think David would disagree with that.
You might as well try.
You might as well try and be perfect. We often fail, but you
Close.
might as well try.
There you go.
That's
Beautiful.
Look at that.
Yeah. I
Twist it
think.
again, but
Let's see what the hood does, because
okay.
at the GOJ it should. You think we're okay? Do we think we've got it entirely in the hood? Does everybody think this is safe?
I think it's safe because I don't think that the thing is what you're trying to do with the hood is you're trying to use it to buffer the angles, right?
Okay, we're good. We're good.
I do
We can
think
see it now.
good.
Yeah, very good. I'm going to keep inflating just as an extra sort of safety, but it looks like it's entirely in the hood, so we should be fine. Yeah, we're fine.
Perfect.
Well, it's hard to see, but this illustrates nicely that you had it completely.
Yeah.
Well, Lobke, well done. Thank you very much. I think we are ready to move on to the next talk. Vikesh, please. Welcome, and please give your talk.
Thanks, David. So I'm going to be speaking about some more upper GI emergencies. And the essence of this talk is not really on how to manage them, but rather you get a call at 10 o'clock at night, and the crux is, when do you actually need to get out of bed, open up the endoscopy unit, and get the scope down? So there's going to be lots of overlap between Peter Jan's talk in terms of foreign body and food bolus obstruction. We'll chat quickly about caustic ingestion, and a bit of overlap again with upper GI bleeding, which was quite well covered by John Morrison. So when you're dealing with a foreign body, and I've included food bolus under the same heading because they essentially dealt with in a similar fashion, the first thing to ask yourself is, will medical therapy suffice? Do you need endoscopy or do you need surgery? If you go down the endoscopy route, you then have to decide, is this an emergent procedure, so done within 2 to 6 hours? Is it an urgent procedure done within 24 hours, or an elective procedure up to 3 days? So that will essentially dictate whether you need to get out of bed or not. And again, as Peter Jan mentioned, it's essential to recognize that most lesions will pass through the GIT even without any sort of intervention. 20% do become impacted, and remember, it's not only the upper GI that they can become impacted in. Don't forget the ileocecal valve and the rectum as well. So there's essentially 3 factors to consider when making your decision, and these are the factors that will determine whether an object is going to be impacted and how much of damage it's going to do. So the factors pertain, number 1, to the object, number 2, to the patient, and number 3, to the anatomical location of the impaction. In terms of the properties of the object, again, radio density, so that would detect whether you would see the object on an X-ray or not. But just to remember, we tend to think of bones as being radio opaque, but fish bones and chicken bones can be radiolucent. Thin metals can also be radiolucent, and it's dependent upon the BMI and soft tissue density of the patient. So don't be caught out if you do an X-ray, you don't see a lesion, it still might be hanging around in the esophagus or in the stomach. So just to be aware of that. The next thing you want to ask yourself is, what's the size, what's the shape, and what's the diameter of the object? And this is important because smaller objects less than 2 centimeters will likely pass through the GIT tract without any issues. Objects larger than 2 to 2.5 centimeters tend to get stuck at the pylorus. Longer items can't navigate the duodenal curve. And shape, because shape dictates the removal device. So, if you have a round object or a cylindrical object, a grasping device is probably not going to be ideal to remove that. You then want to know about other properties of the object, such as whether it's sharp or has pointed edges. Again, you've seen the perforation risk live during the demonstration. But when you have a sharp pointed object, you also want the trailing point to be distally and not orally. So you don't want to cause more injury or cause a perforation while removing the device. So if you have the sharp end pointed away and trailing, that's better than rather having it as a leading point. You then want to ask yourself about the properties of the foreign object. And this pertains to things like batteries, which have, particularly button batteries, which have a high risk of electrical burns in the esophagus, but not so much in other parts of the GIT. The batteries can also leak the internal contacts and cause liquefactive necrosis. So to consider leakage, not just the button itself causing electrical burns. Magnets, and it doesn't have to be two magnets. It can be one magnet attached to some sort of metallic object. And magnets essentially affect their damage by means of pressure necrosis, and this can lead to perforation, fistulae, obstructions, volvulus. Peter Jan already spoke about the body packers and narcotics. So patient factors already discussed as well. Often in the pediatric population, but also again patients with psychiatric conditions and prisoners who are actually using alternate means to try and get out of prison. So you have to bear in mind the time of your ingestion, and patient factors might impact that because you need to determine the reliability of your history as well. Again, crucial to determine symptomatology and to relate that to certain scenarios. The first being complete esophageal obstruction. So to recognize the patient with hypersalivation and complete dysphagia. To recognize the patient who's at risk of perforation, already has a perforation. They may be pyrexial, they may have be peritonitic, they may have meningitis, raised white cell counts and inflammatory markers. To recognize the patient who already has a bowel obstruction, because these patients might need surgery up front. And then again, to assess the risk of endotracheal intubation, not only based on aspiration risk, but also how cooperative your patient is. So this is a essentially summary which risk stratifies patients based on urgency. And you can see very high risk patients or emergent endoscopy only relates to the esophagus. There is essentially no gastric or duodenal impaction